Karibuni, please have a seat. Thank you very much, members of the press. Good afternoon, and good afternoon to the Health Ministry team. Today, as you can see, we are doing things slightly differently. It's Labor Day after all, and I want to start by wishing all of you a happy Labor Day. I want to start off very quickly to go through today's presentation and the update of what has been happening around the country. First and foremost is to just re-emphasize again about the issues that we have in the previous presentations emphasized. I want to emphasize that even as we move on, even as the days go by, we must not forget what we started off by saying, that the COVID-19 disease is changing the way that we live, and it has to change the way that we live. We need to look at technology and the way we conduct official business. Over the last, in the last 1 month or so, both government and private sector have evolved the way that they do business. Meetings have become virtual. Over the last 3 days, I have had 2 meetings with parliamentary committees. All those meetings have been virtual. Yesterday, I had a meeting with the East African health ministers and East African trade ministers, and even those meetings are virtual. We have had meetings with the World Health Organization globally, and the team led by Dr. Amoth went into those meetings in a virtual way. We have been holding cabinet meetings, and cabinet meetings have been virtual going forward, and all committees of the cabinet have also been virtual. So I think there is no gainsaying that it has changed. COVID has changed the way that we do things. But in a manner of speaking, it is also a good thing, because what it means is that going forward, there will be benefits that come out of this behavioral change. The quantity of travel, for example, is going to be significantly reduced, because we know that we don't have to travel to have meetings. We have been meetings even with the Council of Governors, and those meetings have been virtual. So I just want to emphasize that issue of it has changed the way we live. The other issue is the issue of distancing and so on, washing our hands. Because of that, because of distancing, because of washing our hands, what has happened is that bed occupancy in hospitals has reduced. The cases of stomach upsets and stomach problems have been reduced significantly, and this is all as a result of the hygiene measures that people are taking. But coming back to the global disease burden, I think it is established here that as at the 30th of April, a total of 3 million cases globally have 3 million positive cases have been recorded globally, and it is not stopping. It is going higher and higher and higher. Out of that, to date, 769 people have passed on. And that's a large number of people when you think about it. 200,000 people, 217,000 people are a lot of people. And by the time we finish this discussion, there will probably be over 220,000 people who will be dead. That, when you look at those figures, the figure of 3 million, the 217, then you can see that globally, the case fatality rate is about 7%. In other words, those people who have died make about 7% of the ones who have gotten the disease. In Africa, we have now recorded 24,713 cases. Now, let me explain that this must not be seen as necessarily, Africa being better off than the other continents. It is just that it is started later than the other continents. But we were also lucky because ours started late, we also knew what to do because the other countries had done it before us. We had the advantage of knowledge, of global knowledge, and I think that has helped a little bit. But let's not start celebrating yet because we don't know. When you look at in Kenya, when you come to Kenya, today we tested samples in the last 24 hours, about 1,434 samples. Out of those numbers, we have got 8 females and 7 male, and they range between 2 and 79 years of age. And since confirmation, you can see the numbers there, the 3,684 people. We have discharged 2,854, and we are monitoring at least 830 people. And those numbers will go up because we have increased our testing capacity. We have increased the what we call targeted mass testing. For instance, today we have got a big team in town that is going to go some of the areas I'm going to mention in a minute. Moving on, we have got next slide. Moving on, we have got the graph here illustrates, and this is an important graph. This illustrates the number of cases, as you can see, in comparison terms. When you compare what is going on here, you can see this line up here of over 200,000 cases. This is in Italy. You know, it's 203,000 cases. And when you come lower down, you can see Ghana at 1,671 cases. The Tanzanian figure, as at I think 3 days ago or 4 days ago, stood at about 480 cases. And here is Kenya. That figure has also changed. It is not 396 since we did the graph. It is now at 411. 411. Kenya has 411 cases. Now, when you look at the analysis of our cases, where are these cases and where are they coming from? Then you can see we have got 411 confirmed cases. We have got 150 people who have recovered. In other words, 36.5 of the people who have gotten the disease, just about over 1/3 of the people who have gotten the disease have recovered. And remember the global fatality rate is 7%, and you can see ours is slightly lower at 5.1%. And further out, you can see the layout of Kenya, and what you have here is the white spaces. The white spaces that you see there represent areas that have recorded zero positive cases, all the way from, and you can see on the north, in the north you can see the issue of Mandera. Mandera is out there at 8, Wajir is down here at 2 cases. Now the danger with this area here is Somalia, which is here, because Somalia to date has recorded over 500, I think 528 cases already, and that also is a node figure, so we don't know. In other words, the area around Somalia is a worrying case, and that's why we have isolated Mandela just to save them from that, and we have isolated from the borders here so that we can contain the situation in Mandera. You can see that Wajir is following now with 2, and we hope that because of the closure of the border between Mandera and Wajir, if we now need to close Wajir and Somalia so that we don't spread the disease out there. And in Kenya, what you are seeing here is if you look at the red represents figures of over 150, and those are essentially Nairobi out here and Mombasa. And when you look at the coastal region, you can see Kwale down here with 2, Kilifi with 8, and Mombasa at 124. So Mombasa again, in today's figures, for example, today we had 15, and out of the 15 that we got today, 11 come from Mombasa. So Mombasa is beginning to be a worrying situation, and further measures, we have to take further measures to contain Mombasa. Now again, this is just the trend of what has been happening in the country, and let me explain a little bit. 12th of March is when we recorded our cases, and then they started climbing up. As you can see up here, they started climbing up, and then that is when we started the mandatory quarantine at that date. So we went down a little bit on the testing. You remember we had issues of testing kits and so on and so forth. Then we declared the curfew here, and immediately after the curfew, you can see the figures begin to go down. But after that, then we started now testing the people in quarantine at that time. And you can see what happened when we started testing the people. Now, and that justifies the mandatory quarantining. Had we not quarantined when we did, these people you are seeing here, all these figures, would now have been in the streets. And we would be at a much, much higher figure. It is at this point that we are predicting, if we do not have the mandatory quarantine, then you can climb up the 10,000 figures. And you can see this. If this had continued going up, then you can see what the results would have been. And here you can see now, as at this figure, we have got, is going up a little bit. We recorded 12, now we have gone up to 15. But the 15 is also justified by the higher number of testing of the samples that we took. Because if you remember, yesterday we had 777, and out of which 12, we had 12. Now we had 1,400, over 1,400, and we have 15. So you can see the increased testing producing those people. Now, let me just disabuse here some of the cases that have been, and this is why this is important. 0 to 4, people think that when you are young, you can't get the disease. But you can see that we have cases of 0 to 4, 0 to 14. In fact, we have cases as young as 2. You know, that's the case we have. When you look at the age groups, just in terms of the disease, you can see the 15 to 29s, and these are the young people. You can see that they have got, they are getting the disease. The 15 to 29 group, and it's very mobile. These are the people in nightclubs and so on and so forth, in pubs, in the evenings, and you can see now why curfew is an important part of the measures that we have taken. Again, a very active group between 30 and 59. Now, when you look at the gender, if you look at the gender distribution, you have got a 44%, or 181 of them being female, and the blue, which is the bigger group, 230 being male at about 56% of the cases. Now, this is a very important presentation as well, because this was the reverse. When we began these presentations, this was the reverse, that the local cases were much less than the imported cases. But as you can see, the imported cases now have, the local cases have overtaken the imported cases. Now, when we say that people should keep social distancing, and when we say that one person can transmit to very many people, this is the illustration that it has. This is a real case. What we are talking about here, what we have illustrated here, is a real case. And I've got 2 examples. One example is the first case in Kawangware. When the first case came into Kawangware, at this point, that was case number 189. From case number 189, immediate contacts, the immediate contacts that resulted from case number 189 is what we call case number 243, case number 244, and you can see these ones are together, which which means they must have been somewhere together, they were collected together, and they were put in isolation, in quarantine together, and then tested. So you can see that 243, 244, 245, and then at the same time somebody took a bit longer, 258, 269, 270. All these cases are a direct transmission of case number 189. And I think this is a very important thing to see. When we talk about the fact that one individual is crucial and one person, this is all in Kawangware now, and this is real. We are talking about real numbers. Now, then comes now the secondary cases. From case number 258, you can see what has happened. Case number 370, case number 371, because these ones came directly from here. Now you might ask, why is it that case number 258 has got all these numbers and case number 243 does not have? It depends on how much activity this person had, at what time did we discover them, at what time did we isolate them, so that they do not go spreading it. But at the same time, there might be still ongoing people in quarantine who have not been tested on that case, and probably at some point we will then have some other figures growing from that one. This is the case in Malindi, the famous case in Malindi, case number 14. All right, from case number 14, case number 15, case number 23. Now this has gone on to case number 141, the contacts of the contacts, and now we have gone even further from the Malindi, from one Malindi case, and we have no idea what we are going to get now from all these other. This is just an illustration to show you the impact one individual can have in terms of the COVID-19 spread. And then the hotspots that have developed around the country and areas that we are currently working in. As we speak, there is a team, our team of health experts, and sampling is going on in Kawangware, where we now have 13 people. 13 people they have tested positive. Now these 13 people are with us. It's important for us to say that these people are not in the streets. All these people you are seeing here are people who are in isolation centers. And there lies a very important exercise of contact tracing. Because unless we can contact trace these people, it means that these 13 people would now be spreading it throughout Kawangware, and it goes like fire. So the illustration here again in Kilimani, we have 6 cases in Kilimani, Keleleshwa, Halingam, in Kamukunji, 11 cases in Isli. You know how densely populated Isli is. So when you hear that there are 11 cases, we have now got a lot of those people also in quarantine because of those 11 cases who are now positive. So again, some other hotspots, South Sea. Then you can look at Kebra. Kebra, we have been very, very careful to isolate these people as quickly as possible, because again, unless you contain them, and there's a team also that is also carrying out surveillance in Kebra, so that those figures don't keep on growing. Mombasa, you can see Mvita is the main area. This is where we had an 87-year-old herbalist who died in that Mvita area, and in all these cases actually can almost be tracked back to the same source. Again, Mombasa, KPA has been a big challenge. We believe that we have now kind of managed to collect and gather the people in KPA. We are watching it very carefully, but we have done quite a bit of testing within KPA and also isolated quite a number of people. But as you can see, the figures in Mvita are really growing. You know, and it is imperative that persons living in the Mvita area, what all these figures tell you is that they are a call for action. If you live in Kawangware, you know now that there is a center in Kawangware, and the disease is spreading in Kawangware. You know that if you live there. If you live in Mvita, you know that the next person you are talking to could very well be COVID-19 positive. Therefore, you need to take action. You need to keep your distances. You need to keep washing your hands if you come into contact with anybody. If you go to the market, you need to make sure that you are not touching stuff that has been touched by other people. And at least you keep on washing your hands. Anybody with a shop in Mvita, anybody who has got an Italy or whatever it is, you must follow the rules that we are making in order for us to keep Mvita safe. Again, on the issue of the people who have died, this is an interesting one, and the figures that we are finding point at females recovering a lot faster and in bigger numbers than the male population. As you can see, 46% of the people who are positive are female. But when it comes to the death figures, only 19% of the people who have passed on out of the 21. Is it 21? Yes. Out of the 21 persons, because today we have 4. We have increased the death by 4 people, and out of those, 19% are female and 81% are male. It is we believe that the reason why there is that disparity is because of preconditions that exist more in male than female. You know, high blood pressure, heart disease, etc., etc., etc. Again, we had established that the imported cases, out of the deaths that we have, local imported cases were only 2. Now it is local transmission that is killing our people. As far as the age groups are concerned, again, take note of 2 things. Number one is that, as I said, we have had a death in that area. But I want you to take note of between 15 and 30 years old, nobody has passed on. Between 15 and 30 years old. What that tells you is because you saw the figures of the infected persons, and you can see that between 15 and 30 there is no death. What it tells you is that this group is the one that can spread the disease. And this is why we are telling Nairobi people, stay in Nairobi. Please don't take this disease back to the older people up country. This is a perfect illustration of that circumstance and the reasoning behind. We have always told you that we are taking decisions based on empirical evidence and data. This illustrates that and explains it. When you go further down, you can see that between 30 and 59 and above 60 is the same figure. And if you break this down a little bit more, you'll probably find that this number of the 10 would lean more towards the above 50s than you would in the lower 30s. So that whole graph is to ask kindly and to urge people who are between 15 and 30 years old to note that you are carrying, you are passing it on and killing other people. Instead of contacting other people, distance yourself from them. At this moment in time, call your mother. If you're in Nairobi, don't go to see your mom. Call your mom. Talk to her for the time being. A time will come when you can travel. Again, we have been talking about testing capacity, and this is a question that has been raised. These are the areas that have been carrying out the tests, and you can see as at now we have had 21,702 samples, and within the 15 labs that we are continuing to expand testing capacity in other areas. I believe that as we expand, then even you can see here, for instance, where is Wajir? Wajir is, yeah, you can see, for example, we have opened out Wajir, for testing. We are hoping that in the next couple of days, we are going also to open up Mandera for testing. So, and we have continued to expand our testing capacity. Our ongoing activities include expanded testing. For example, as you know, the presidents of both Uganda and Kenya have told us that drivers must be tested. So what the protocol we have established for truck drivers here is that we will test them in Mombasa. So before a truck driver leaves Mombasa, you must make sure that you have done your tests. You can do your test 48 hours before you leave. But what we are telling them now, we will not allow anybody, any truck driver going to cross the border. Before you leave, before you get into a vehicle to depart, please make sure that you have been tested. Because what it means is that if you don't do that, then the Busia border, you know, there are so many people there at the moment. You are just going to increase the problem. And for that reason, therefore, our health officials are under instruction to ensure, and we are asking the enforcement agencies to ensure that drivers leaving their destination to go and cross the border have all been tested. It is also, as you know, to contain the disease because of the stopping of the areas that long distance drivers stop in so many places. So we are saying that must be done. Again, we have given the restaurants and eateries protocol, and we will not hesitate. Let me just say this: we will not hesitate to close the restaurants that are not observing what we are saying. And it will be very expensive for them because you have already tested your people. You have already spent money, and then you get closed down. So please, as we move on, let's make sure that we keep that protocol. Again, we are continuing targeting the health workers. Any health worker is an ongoing process at all times that health workers must be tested so that, again, they do not affect people when they are being treated, when they are treating them. Additional, as I said earlier, additional testing capacity is going into Busia, Machakos, Kitale, and also Malindi, and as I mentioned earlier, an additional one there is Mandera. We are also scaling up the training of health workers. Again, is a continuous exercise. We have particularly targeted health workers who are going to be using ventilators because there is specialized training for people who are going to use ventilators. Continuing of mass productions of PPE. Today we are here with Airtel, people from Airtel who have come to make a presentation to us of some 6,600 locally made PPEs. So when we promised that we are going to increase the supply of PPEs, it is already happening. And within the next 2 weeks, we do not believe that there is going to be any county that is going to be saying that they do not have PPEs. You must remember, however, that is a continuous exercise because most PPEs are used only once and then left out and then thrown off or incinerated. Travel restrictions, as we have said, are still on. There is nothing that has stopped. All the measures that we have taken are there, and we still urge the public to be aware of the matter of distancing and all the other hygiene measures that we have taken. So that's the end of the presentation today. I just wanted to illustrate some of the things that we have been talking about, and it is important for us to I think when it is done this way, graphic presentations sometimes have a bigger impact in people, and they understand things better when they are illustrated as they have been. Thank you very much. I need a paper.
Thank you. I am Mark Namaso from KTN News. I'm asking this question on behalf of healthcare workers. Many of them have been forced to stay away from home and seek accommodation away from home during this crisis. The question is, were there funds allocated for their boarding fees, and how much was it?
My name is Purity Museo from KBC. My question is on your directive to have the truck drivers tested, and that also with the restaurant workers. Probably you can expound on the validity of every test, because I understand they will be making many trips, the truck drivers. So what's the validity of every test? And then another question would be on, we are on a new month, and you are explaining about a curve, how we have been doing in the month of April. Probably what are we looking at as we enter the month of May? Do we expect the curve, are we already at the peak, or things are still not okay for the nation? And so lastly, there was a time the CAS for Health, Dr. Rashid Aman, talked about the home care program, especially for people who are in quarantine, because it's a bit expensive for people to stay in quarantine and pay what they're supposed to pay. Probably when are you thinking about launching this home care program where people can quarantine at their own homes?
Thank you very much. Let me first of all take those two, then I can take another two. First of all, the issue of Mark, the issue of whether what we are doing with the workers. In fact, in most places we have financed them ourselves. For example, when you go to Kenyatta, KU, we have actually furnished some apartments where they are now staying, and in circumstances where where workers are supposed to stay inside the hospital, then it is our job to support that financially. Purity, on the issue of the drivers, what we are saying is that every 14 days you will be retested. Okay, every 14 days you are retested, because when you travel to Uganda, whatever, take 14 days to come back, every 14 days you will be required to be retested. On the issue of the home care, yes, it is a plan that we continue to have. And let me emphasize this, because it is so important. The only reason why Kenya has not adopted, a flat home care program is because of our indiscipline. Let's be honest. There is no other reason. In Germany, in Sweden and those countries, they have got basically perfect home care quarantine policies, essentially because they will obey the law and they will obey the rules. You have yourself seen, they have just established for you, the culture here is such that home care programs will be introduced very slowly, and at a time when we think and know that we are taking this disease seriously. There has been cases where we have done it, where we have adopted home care. For example, as you know, there will be people who will be coming from India. Some of them will be hospital cases, and we are not going to quarantine them in quarantine facilities. We will ask their doctors to be the supervisors of their home care, of their home care programs and home care quarantine. But as for the general public, we do not still feel confident enough to launch that program. You also asked about the testing. Let me also say this, that government hospitals are now offering testing at a much more reduced rate. I know people are talking about 10,000, 15,000 for testing. Government hospitals are charging between 2,000 and 4,000 shillings, and we reduce those prices so that people who need testing can actually get it. Those are subsidized testing rates. Right. Yeah, sorry. The modeling, I think I'll let Dr. Amos talk about the modeling. Let me just take two questions and then you can come and do your modeling.
Right, thank you so much. Seth Olale, NTV. 4 deaths under 24 hours. Maybe this is the highest number in terms of fatalities. Is it something to worry about, even as we start a new month? Second question would be, are there standards maybe in some of these quarantine facilities, like standards? Because we just had a report of a woman with a baby, an infant, who were subjected to very inhuman conditions. So Kenyans are asking, are there supposed to be at least moderate standards in terms of quarantine facilities? Then my last question would be regarding, and of course, I know you're not the immediate accounting officer in the ministry, but again, prioritization in terms of budget and expenditure. Kenyans are asking questions in regards to where money was spent up to this point, and the president indeed this morning said that no one will be spared and he's going to take action. Will the ministry follow suit? Thank you.
Sam Ogena from Citizen TV. Mine is actually a follow-up to Olale's, and from your statement, Waziri, you actually yesterday on your Facebook account, you said that there was actually a cohort of, let me just get it verbatim, a cohort that believes in exploitation. So my question
can you read the context? Because
this is what you said.
If you say the population is dense,
this is what you said.
You can mean the population is foolish or the population is high.
Precisely. Okay. Let me read it to you verbatim, that particular bit. So you said, and so I'm here to let you know that amongst us is a cohort that believes in exploitation and that thinks that by spreading lies, innuendos, and propaganda, I'll be intimidated.
Exactly. Now, you see, when you say cohorts, it sounds like the ministry cohorts. But when you read the full sentence, then it becomes very clear that I'm talking about those people out there who are spreading malicious rumors and what have you. Now, let me respond this way. You have seen for yourself, even in the media, in the social media, somebody even saying that all the advertising that is being done in this ministry is being done by my company. You know, you have seen that yourself, and I would like to declare here and now, I have never done any business, not only with this ministry, but with any ministry in government. It is my policy, at least when I was running private business, because I have also got to distance myself from the company. But even any company that I'm involved in does not do business with the government. And this is clear. So when I say that there are those kind of people out there spreading malicious rumors, it is true. It is absolutely true. And not that it is affecting me, because, you know, I've got my eyes on the ball. I know what I'm doing. And as for the issue of the budgetary expenditure here, again, it is very easy, you know, to put things out of context and make it look like there is theft, you know, going on in the ministry. And in the same Facebook post that I did, you should also have read that I said that anybody who is culpable in terms of any sort of 1 shilling expenditure in the COVID-19 funds, if indeed there is one, will not be spared. And I meant it, and I mean it even now. But I would like to get to the point where that is the case, because I also know some of the details that are being explained away as thefts are clear expenditures. You know, for example, I'll give you one example. When you say, for instance, that there is 42 million shillings spent on ambulances, I would like you to tell me, you know, Seth, I don't know, maybe you can tell us how much you would pay for an ambulance one day, you know, for 1 day, an ambulance 1 day, taking you from wherever you come from, you know, or from Nyeri, where I come from, to bring you to Nairobi and take you back on the same day. How much you'd pay for an ambulance like that? What we are talking about here, for example, the 42 million shillings, 5-point-something million out of that is tax, first and foremost, that's VAT. Then you take the other money, you take 15 COVID-19 ambulances, all right? You take 15 ambulances, you put in those ambulances the health workers who are working in those ambulances, you put the PPEs those people are using in those ambulances, you give them 2 shifts of people, because you have got 24 hours. You are in with that ambulance for 24 hours. Okay? There are 15 ambulances. You have got them for 12 weeks. That is 3 months. You know, spread that over 3 months and do the maths. And tell me where you can get an ambulance like that in this country to to manage the kind of things that we are managing. So do the maths. So what I'm saying is this: it is always good to put things in perspective, so that when you put a figure, it is a figure, and to ask yourself, is this a figure for a month? Is this a figure for 6 months? You know, how much time are we talking about? If you have got 200 or 300 people who are working over a period of 3 months, 4 months, and they are locked up somewhere taking course, they have to eat, they have to be fed, they have to take tea, they have to be there. What are they supposed to do? Are they not supposed to eat at some point? So let's put things in perspective. Not to say that we are not investigating everything. Here, every shilling is investigated for and accounted for. So I just want to say that not to defend in a case, but to be clear that the principle that we have adopted is that there will be no shilling that is going to be spent on anything else other than the COVID issues that we have raised. So I want to ask Dr. Amos to come and respond to the other issues.
Thank you, Waziri. I think I'll start by responding to the question regarding from Purity, regarding the numbers and what we are likely to see going forward in the month of May. One, this will be determined by the targeted mass testing that is taking place now in Kawangware, Isili, and Vita in Mombasa. But looking at this graph, and that is why I told him to bring it back. Basically here we are dealing with established local transmission. If we continue with the measures that we have taken before, the hand washing, the use of sanitizers, wearing our face masks, and physical and social distancing, and of course we maintain the restriction of movement, then it is likely that this figure will just hover around what the curve is showing. However, if there is any breach in terms of what we have been preaching, if we go outside there, then you can be able to have an upswing in terms of the figures. Regarding the quarantine sites, we have standards and guidelines which ensure that we have psychosocial support of those people who are there. We have standards regarding safety if you are in a quarantine site, and we also have standards in terms of hygiene, so that wherever you are staying, the rooms are clean, the linen is changed as frequently as is probably possible, to ensure not only the safety of the people who take care of the quarantine sites, but of course the quarantinees in those particular sites. So I think based on the results of the mass testing, we'll be able to give you our figures going forward. And modeling is not a constant parameter, it keeps on changing, taking into consideration new data. The result of your modeling will be based on the inputs of the data you key in. It will be able to give you. And we cannot say that, for example, the figures that we had for April may obtain in the month of May. So with this new information, we'll be able to give you further information going forward after analysis. Thank you.
Thank you very much.
Asante Waziri.
Asante, asante.
Thank you very much.
Namaste, namaste, namaste.
Media, please, if you run down, basically it's not event downstairs, where the CS will be receiving DVDs that are documented by the actual. Just very quickly go down, please.